And I'm going to be talking about really what we can do to give our patients that wow effect, and that involves enhancements. I think Steve Brent gave that very nice study, and the data he showed I thought was really very good. But you saw about 8–9% of patients needed excimer laser photoablation to improve their visual outcomes. So what are expectations for 2010? When patients have cataract surgery, when patients have refractive cataract surgery, they expect no pain, immediate visual rehabilitation, certainly far, maybe near as well, and they expect no complications. The last thing they expect is not to have a good outcome or to have to come back for more surgery. So this is my prototype. I'm working on this nomogram now on how I can make my patient incredibly unhappy following a refractive IOL implantation. And when I show you this kind of tongue-in-cheek, think about how many of these things you do yourself in your practices on a routine basis. And if a patient comes in and has paid their $2,000 or $3,000 to have a refractive IOL placed, and they end up with refractive problems, what can we do to make them extraordinarily unhappy? Well, first of all, start by leaving them with a significant refractive error following a multifocal IOL, or a accommodating IOL for that matter. So leave them with a diopter of cylinder and a diopter of hyperopia as well. That will make them very unhappy, which speaks to the issue of the importance of correct IOL selection. Then don't tell them that this might occur during your preoperative consultation, so never mention preoperatively that the patient may have this problem and they may need a refractive enhancement after surgery. If you don't tell them, it'll surprise them even more. So the third pearl for making patients incredibly unhappy is wait as long as possible to do the enhancement. Now, you can do a refractive enhancement with a monofocal lens or a multifocal lens as early as a month, but if you wait 6 months or a year, maybe the patient will move somewhere else, maybe the patient decide they don't want to come back and see you. And there's a lot of doctors who still have what I call the wish technique. They wish that the problem would just go away rather than doing something about it. If you want to really incense your patients, charge them for the enhancement. So charge them for your surgery and then charge them for the enhancement as well, and that will really make them extremely unhappy. And then finally, do PRK instead of doing LASIK. That'll just put them right over the edge. So these are my pearls. Now, everything I just said, do the opposite. So pearl number one is patients will tolerate refractive errors, and this could not be farther from the truth. These patients need to be on spot. And you know something? We have this kind of paradigm right now that we think that cylinder is the #1 rate-limiting process for most of our patients. 70% of our patients have a half a diopter or cylinder more, and kind of the conventional wisdom we all speak of is that a half a diopter of cylinder is acceptable. And I would say to you, well, if a half a diopter of cylinder is acceptable, why not aim for 0 cylinder? I don't want to meet my patient's expectations. I want to exceed my patient's expectations. So a patient who's happy with a half a diopter is going to be even more happy with less. For that reason, I do a lot of LRI enhancement. This is the blade that I use. My name's named after it, and it's made by Accutome. I like it because it's got a 15-degree angulation. I have no royalties on this, but I like this for doing my LRIs, and I do a lot of them at the slit lamp, and I use my very simple nomogram. Basically, most of these I do 1 clock hour on either side for about 3/4 of a diopter of cylinder. And this can be done very easily right at the slit lamp. And on an average day in my office, I may do this 5 or 6 times on a day to treat a half a diopter or 3/4 of a diopter of cylinder to improve my results. But let's talk about excimer laser enhancements. And these will be needed, depending upon who you're talking to, between 5 and 15%. I think accommodating lenses need a little bit more because of the unpredictable nature of where the lens sits in the capsule or bag. So you're going to be doing this on about 1 in maybe 20 to maybe 1 in 8 of your patients. So do you need to learn LASIK? No, you don't absolutely learn to do LASIK. And if you're not doing LASIK, start with PRK. But I think you need to start doing some of this. To be a comprehensive refractive surgeon, you need to do cataract surgery and corneal refractive surgery. And if you don't, have someone in your practice. But the idea that you can find someone in your neighborhood who will assume all of your complications and do your enhancements for you for free is probably not realistic. PRK gives excellent visual results. Marguerite has been a tremendous champion, and I see her results are superb. And I think that this is a way of starting out in the refractive arena doing corneal surgery. However, if you want to really maximize your visual result, I think LASIK gives that patient that wow effect of the next day they're seeing well. And for my post-cataract surgery enhancements, I'm not doing 9.5 millimeter flaps. My flaps have become smaller and smaller, so for residual myopia, I'm doing 7 millimeter flaps on these patients who have 3 and 4 millimeter pupils. And by making the flap as small as possible, we reduce the risk of dry eye. The planar flaps, the thin flaps, the reverse side cuts have all been shown to optimize our results. And I think all these things can give us really wonderful results. And when you do a 7 millimeter flap, it's almost like the patient's cornea wasn't touched. So when can you do your excimer laser enhancements following cataract surgery? Well, I'll do my LRIs as early as 2 weeks. When I'm doing with a multifocal IOL, I'll do PRK or LASIK as soon as 1 month when they're refractively stable. For common IOLs, I always do a YAG capsulotomy first, because even if the posterior capsule is clear, when you YAG the posterior capsule, the lens may shift in position and change your refractive results. So I usually will wait a month after my YAG capsulotomy, so about 4 months after surgery. For some little pearls, when patients have multifocal IOLs, or even patients with aspheric monofocal lenses that are not centered on the pupil, perform an argon laser iridoplasty, and I'll show you that in a few seconds. And a lot of you are interested in custom ablations for our patients, and I do custom ablations on everyone except for my multifocal IOLs, where I think the conventional ablation is certainly optimal. And this has been said time and time again, and I'm so proud of our group of us as ophthalmologists who have really come to the realization that optimizing the ocular surface is certainly the #1 thing we can do to improve refractive outcomes. Vision starts with a tear film, and with an unstable tear film, whether it be dry eye or meibomian gland dysfunction, it's not going to do well. And the routine use of cyclosporin, nutritional supplements, azithromycin, I think have really improved refractive results. Now, a lot of patients will have an angle kappa where the lens is not centered in the capsular bag relative to the pupil. This is normal, and most patients do just fine. They have no problems with this at all. You just leave it alone. If you see this, there's not a reason to treat. But if I'm going to be doing an excimer laser enhancement in this patient, I don't want to be centering my ablation on a decentered lens. So I'll always go back and do an argon laser iridoplasty. I also do this on patients who are unhappy with their quality of vision. But if they're happy with their quality of vision and it's a refractive result, I will still go back and do a little argon laser iridoplasty. This is for Carlos. If you can remember number 5, Carlos, you can do this. 500 milliwatts, 500 microns, and 500 milliseconds. And I place the 4 spots in the periphery where I want to move the pupil. And here's your patient before and after, now with the pupil centered over the lens. Now I can go back and do my excimer laser ablation. In conclusion, excimer laser enhancements following refractive IOL surgery is extraordinarily important. It improves surgical outcomes and patient satisfaction. And it has to be something that we either have to be comfortable with or have access to someone who can do this for us. And I think that the treatment of residual refractive errors is the #1 concern in achieving patient satisfaction with refractive cataract surgery. Thank you for your attention.